Good day to one and all. I was tasked to give a short lecture on principles of antibiotic therapy, and we'll go to the next slide straight away. So, this is taken from our infectious diseases textbook, Mandel, and this is from the chapter Principles of Anti-Infective Therapy. So, I just wanted to show some of the text on a brief history of antibiotics. And it just shows here that the ancient peoples, Greeks, Chinese, Egyptians, used natural substances to treat infections in the past. No? And some have been shown to have antimicrobial effects. No? And however, in the 20th century, Dr. Paul Ehrlich won the Nobel Prize in 1908 for his studies of the chemistry of antibody-antigen interactions. So he reasoned that because chemistry governed the benefits of immune serum, it should be possible to recapitulate those benefits by creating or discovering small molecules that could similarly chemically interact with microbes. So he coined the term chemotherapy to describe the use of small molecules to treat diseases and principally infectious diseases. So chemo does not always mean therapy for cancer. So Ehrlich's efforts led to his discovery of the first anti-infective small molecule, arsphenamine, which is a derivative of arsenic, which he found could successfully treat syphilis. So the drug became an enormous commercial success, but quickly faded when it was realized that the drug had potentially fatal side effects. Nevertheless, the sophisticated chemical library screen Ehrlich designed and conducted to discover arsphenamine became a blueprint for subsequent drug discovery that ultimately led to identification of many other antibiotics and other drugs as well. So the word antibiosis, meaning against life, was coined in 1889 by the French scientist Jean-Paul Villermin. He used the term to refer to the process of one creature destroying the life of another to sustain its own. So half a century later, in 1942, future Nobel laureate Dr. Selman Waksman built on this definition, coining the term antibiotic to meet a chemical substance of microbial origin that inhibits the growth or the metabolic activities of bacteria and other microorganisms. Thus, the term antibiotic technically refers to a natural substance produced by a living organism to inhibit the growth of another. However, in common parlance and in the remainder of the chapter, the term is often used more liberally to encompass both natural and synthetic antimicrobial substances because at the clinical level the distinction is not important. So here we go. Alexander Fleming discovered penicillin containing mold byproducts in 1928. And penicillin's first use as a purified substance was not until 1940. Thus, the first safe and effective, those are the keywords, safe and effective, specific antibiotics inclusive of synthetic drugs to be clinically deployed were the synthetic sulfa agents discovered by Dr. Gerhard Domack and his team in 1931. Okay, so the first sulfa drug, Prontosil rubrum, had miraculous curative effects in mice with lethal bacterial infection. And by the late 1932, news of the miracle had spread, and local physicians began to treat patients with sulfa drugs before the animal studies were even published. Okay, so on May 17, a colleague of Domack used a new sulfa drug to cure a 10-month-old boy who had a fatal bloodstream infection caused by Staph aureus, a bacteria that we know is prominent these days. And this child, on May 17, 1933, was the first person in history ever to be cured of a lethal bacterial infection using, again, a safe and effective antibiotic. So for this part, I just wanted to highlight that in the first sentence, it says as powerful as sulfa drugs were at saving lives, they had limited or no efficacy against many types of infections. And purified penicillin, when it came along, was far more effective. And if we go straight to the last sentence of this particular paragraph, indeed so powerful was penicillin at reducing death from infections that within 3 years of its widespread availability in the United States, experts were already speculating on the end of bacterial infections as a significant clinical problem. They thought it would end bacterial infections. And as we know today, that was not the case. All right? So we'll skip the others and we'll go to this quote by Felix Marti Ibanez of 1955. Antibiotic therapy, if indiscriminately used, may turn out to be a medicinal flood that temporarily cleans and heals, but ultimately destroys life itself. And we know this, no? So the term is indiscriminately used. So that phrase is very important. That is a challenge for all doctors, especially those who will be using antibiotics, to make sure that use will not be indiscriminate, and it should be reasonable whenever we prescribe antibiotic, because the problem is it may ultimately destroy life itself. Through how? Okay, through antimicrobial resistance. So here's a term entitled Selection for Antimicrobial Resistant Strains, and it starts with this. This is just a representation of any organism. No, it can be a human. No, it can be in most organisms, no, including humans, who have no antibiotic exposure, resistant strains are rare. So most of the strains or bacteria that colonize, for example, a person who has not had any antibiotic exposure, will have susceptible strains or the weaker strains, no, of bacteria all around in the body. Remember, we are colonized. No, bacteria live in us. No? So, however, there are some resistant strains in our bodies. However, they are rare. Now, the problem is if we are exposed to an antibiotic or antimicrobial, the susceptible strains, the weaker ones, of course, they get killed off because they were exposed to an antibiotic. So what happens is they kill most of the weaker susceptible strains, and the resistant strain is the one that remains, and of course reproduce and become the dominant strain in the body. So the next time these resistant strains become aggressive and they become an infection, the patient will have a type of infection that is resistant to antibiotics. So this is very important, selection for antimicrobial resistant strains. Now there's also this emergence. There's also this concept of how emergence of antimicrobial resistance occurs. So again, we start with a susceptible bacteria, and because of mutations, no, and we know of mutations, no, changes in the DNA, no, and then the mutations may result in the susceptible bacteria becoming a resistant bacteria. But there's also another way. A susceptible bacteria, and I call this the bad influence slide. No? So if you have a susceptible bacteria that gets exposed to a resistant bad influence bacteria that has resistance genes, the susceptible bacteria may incorporate, and the resistant bacteria may transfer some of those resistance genes to the susceptible bacteria, and that susceptible bacteria may end up becoming resistant. So this is called the bad influence slide. Okay. And then there's also another mechanism of resistance, which is efflux pumps. So substrate here means the antibiotic. So some bacteria, when they are exposed to antibiotics, some bacteria are able to spit out the antibiotics, such as so, right? So that these I would like to thank my mentors, Dr. Steve Lerner, um, Dr. Glenn Kutz, for some of the slides, that have been very useful. They're very nice slides, showing how, in this particular case, how a bacteria is able to spit out antibiotics. So it's a way of the bacteria, um, countering the effects of the antibiotic that's supposed to kill them. So the problem of antimicrobial resistance, of course, the main determinants are antibiotic use, and as we mentioned earlier, indiscriminate antibiotic use. The other is poor compliance with hygiene measures. No? We mentioned that bad influence slide. So a bacteria, for example, a patient coming in to a hospital environment, for example, where in the hospital had poor cleaning measures, for example, and the resistant bacteria, once the person gets in contact in the environment, those resistant bacteria then, um, the resistance genes can be transferred. However, the relationship between antibiotic use and resistance is complex, and it's so much more than what I showed previously. So these are other factors. No? Antibiotic use in the developing world is still poorly controlled in both human and animal medicine. The problem includes self-medication, and sometimes that becomes indiscriminate, as we said. And also poor adherence to completion of antibiotic regimens. No? If you don't complete and eradicate the present infection, it may relapse, and because of antibiotic exposure, it may end up being or developing into a resistant infection that was previously not so. Now, low quality antibiotics, again, if your antibiotics are not not good, it may inadequately treat an infection, again developing resistance, and of course misuse. So antibiotic resistance is likely to continue to increase. No? And in the past decade, um, there was a paradigm shift, and antibiotics are now considered precious and potentially finite rather than limitless resources. Okay, so again, inappropriate use can be overuse, no, or misuse. No? So overuse is when using it unnecessarily, or when continuing it when it's no longer necessary. And misuse means wrong antibiotic for a certain disease, for example, or wrong duration, whether too long or too short, and then the wrong dose, especially underdosing. And this is just a slide showing when the antibiotics were discovered and then introduced, and when resistance first developed. So, for example, penicillin G, discovered in 1940, introduced in 1943, but as early as 1940, there was already resistance that was reported, and down the line. Okay, so as you can see, streptomycin, discovered 44, introduced 47, resistance as early as 1947. So what does this slide just show? That the bacteria are able to adapt and develop resistance, because, as I always say, these are living things. They want to live. No one wants to die, so they want to live. So they develop means to be able to live, and that's resistance. And this graph, or illustration, just shows the many different antibiotics. First 1940, 43 penicillin was discovered. In 1950, tetracycline, then erythromycin and methicillin. But as you can see, as early as 1940, there was already penicillin-resistant staphylococcus. No? And in the golden age era of antibiotics, wherein tetracycline, erythromycin, and methicillin were discovered, there was already tetracycline-resistant Shigella and MRS, methicillin-resistant staphylococcus, and then down the line. And recently, um, there have been new drugs, no, in 2010, ceftaroline, 2015, oritavancin, 2016, ceftolozane, tazobactam, and ceftazidime, avibactam, and um, going to 2019 and 2020. No? So we really need this, no, because there was a bit of a little bit of a drought in between the golden era and this 2015, 2016, 2018, 2019, 2020. So we need more antibiotics, you know. As we mentioned, it's become a finite, precious resource. So we need more antibiotics, and we need to support and do drug research and development. So now we go to the meat of today's presentation, and I just wanted to show the fundamental principles of antibiotic therapy. So number one is the proper selection of empirical antibiotics starts with an accurate differential diagnosis that includes the likely bacterial infection. So when patients come initially and a doctor sees the patient, no, of course the diagnosis is not yet 100% certain. But of course, a doctor will take a history and a physical exam, of course, and also order some laboratory tests to confirm what the doctor is thinking, what you are thinking. Of course, this is your impression, and you are thinking of a number of diagnoses, and these are your differential diagnoses. No? So based on your differential diagnoses, no, 1, 2, 3, or 4, for example, you will be starting empiric antibiotics based on your differentials, no? Especially the ones that are the most likely, your main impressions. Okay, of course there are things that you have to rule out. You don't need to cover if the likelihood is less, but if the likelihood between the four, for example, 5 differential diagnoses and the first 2 are your main impressions, those are the ones that you will cover for. No? Okay, so, and you have to be careful also of mimics, no? You have to remember that there are some conditions, no, that may not be may not be an infectious disease, but may present the same way, such as fever, abdominal pain, for example. It may be a pancreatitis, no? So be careful about mimics, no? But again, your selection of empiric antimicrobials will be dependent on your most likely differential diagnosis, your the diagnosis that you're considering as highly likely at the time. No? Okay, and also when you are faced with colonizers and contaminants, so not all bacteria that grow in culture need to be treated. So, for example, a blood culture blood cultures, you take 2 sites, and if it's just one site and it is a coagulase negative staph, for example, it's only from one site, and clinically the patient does not look like he has an infection, then you can label that a contaminant. No, so just just a problem when the medical technologist took the blood and probably some skin bacteria or flora was able to get into the blood culture bottle. And sometimes colonizers, no. For example, in our phlegm or respiratory secretions, it's very common to have yeast, okay, or candida, for example. Most of the time, we don't treat that, no, except for when it seems likely that it is a true pathogen and not a colonizer. So again, number one is to select your empiric antibiotic based on your most likely differentials at the time. So the second principle is, even in a patient with a bacterial infection, treat only when therapy will alter the patient's clinical course. So the one that was, and all these are from Mandel, okay? Because this again, this is the um, Bible of infection doctors. No? So the examples that they gave were, number one, osteomyelitis in a chronically exposed bone. So usually, um, an exposed bone will be very prone to infection, and in this case, if it has osteomyelitis, it's already infected. So then, the example that they gave was that, for example, if you treat, but there is no planned procedure to to close it, to eventually prevent future infections as well, no? Then you cannot just keep you cannot keep on giving antibiotics continuously, at treatment dose. And the same goes for the terminally ill that are that have uh, no to zero chance or very very low chance of surviving. And doctors have seen lots of cases, and of course they kind of know when a patient is going. And sometimes there is the dilemma on whether to start. And for example, there's fever but blood pressure is very low, and you are called in, for example. Will you still start, or will you discuss it with the family? Especially if, for example, if it's a terminally ill and you have a very resistant bacteria that's causing the infection, and the patient is already dying um, because of not just the infection, for example, but also from a terminal cancer plus the infection. And then this is, you don't just automatically start your antibiotic. Of course, you discuss to the family the prognosis, because sometimes the family will just say it's okay to hold off um, on the expensive antibiotics, for example, because you know they have accepted the poor prognosis of a patient. So there's also some ethics involved in this second principle. So the third principle, empirically target microbes that cause the disease in the differential diagnosis. And we touched on this earlier. Of course, empiric treatment is you pick the antibiotics that will treat the most, as I mentioned earlier, the most likely differentials. No? And that's why it's good to classify your differentials as, for example, these are my main impressions, my main differentials, and these ones are less likely. So I just want to rule them out. So ruling out means you focus your diagnostics on these, no, so that you can rule them out. But for the main impressions, main differentials, you treat them. Okay, you use antibiotics that will cover for these diseases. And of course, you choose the antibiotics that are safe and effective, and evident, of course, evidence-based, meaning there is evidence that they are safe and they are effective. But safety and effectiveness are not the sole reasons for choosing an antibiotic. No, like for example, if it's too broad, very broad, you don't need it. No, but it's safe and effective. You also have to consider the or how broad the antibiotic is. Or of course, you have to go not too broadly, but also not too narrowly, because you might miss the enemy or the bacteria. No? And then the last bullet shows nosocomial versus community acquired. Of course, like the most common here is, of course, in nosocomial infection, no, meaning an infection acquired in the hospital setting. No? This is a risk factor for Pseudomonas versus a community-acquired infection, bacterial infection. Pseudomonas is very unlikely. Okay, so do not use or it's not recommended to use an anti-pseudomonal agent for community-acquired infections in general, while it's recommended to use an anti-pseudomonal agent in nosocomial infections. Okay. So fourth fundamental, a lower threshold for empirical therapy should be used in critically ill patients. No? So if you have a hemodynamically stable patient, no, then you have more time to diagnose a patient. You don't have to rush to give a broad spectrum antibiotic. No? So, and that's why in some guidelines you are given more time if a patient is stable. No? Okay, so you have to balance diagnosis and treatment. No? In a stable patient, you can do more diagnostic tests so that you'll be able to be you will be guided on what best to start for patients. So versus someone in shock, no, hemodynamically unstable or critically ill, then you have to start quickly. No, so like for example, blood cultures. You order blood cultures right away because you want to identify the bacteria, and site-specific cultures, like for example, if pneumonia, a sputum gram stain and culture. If UTI is what you're thinking of, then a urine gram stain and culture. But you have to start antibiotics, especially if it's a septic patient or a critically ill patient. You have to start antibiotic within the hour, okay? Especially in septic shock, okay? But again, give just some amount of time for the culture specimens as well to be extracted. Now, again, for critically ill treatment, usually should be broad or broader than stable patients, but the broadness should not be unreasonable. It should be still reasonable. That's why you need to get the clinical information from patients and their families, the history, the risk factors of patients, so that you know how broad you will go. Okay, and it always should be evidence based. So evidence you can get from the history of patients, no? And sometimes the physical exam. So fundamental number 5, host factors affect the breadth of empirical therapy by altering likely microbial causes of infection. No? So again, so the severity you take into account, but also the host itself. For example, if a host is weaker than usual, so immunocompromised, then you will have a broader differential diagnosis. No? So because some bacteria, some microbes do not affect the healthy persons. No? But if you have a weak patient, then the less common organisms may be the ones affecting your patient. No? So you take that into account. Now, being immunocompromised doesn't mean this patient has resistance. No? You still have to look at the risk factors for resistance. No? So having an immunocompromised patient doesn't give you liberty right away to use the antibiotics that are reserved for resistant infections. Okay. So in some, immunomodulation helps. For example, in sepsis, because there's a dysregulated host response, an overly active host response that may hurt the patient, then immunomodulation such as steroid may be used. So again, the host factor and the host response may also, you also take into consideration when you start your therapy. Now, how about number 6? Pharmacokinetic and pharmacodynamic principles can influence optimal treatment. No, so for example, there are antibiotics that have large volumes of distribution, but they have decreased levels in the blood. Like for example, macrolides, tetracyclines. No? So these are things that you'd like to avoid in bloodstream infections as the sole treatment. No? Okay, so how about organ penetration considerations? No? So there are drugs that have poor central nervous system penetration, like piperacillin and tazobactam. No? So for those that need Pseudomonas coverage, they use ceftazidime or cefepime. No? Now, amikacin, fluoroquinolones, aminoglycosides, cotrimoxazole have good urine penetration. And of course, prostate, fluoroquinolones are known to be very good and have very good penetration along with cotrimoxazole into the prostate. So those are things that you have to consider. For this particular infection that I'm considering, is this particular antibiotic good in terms of organ penetration? Of course, bone, clindamycin, cotrimoxazole, fluoroquinolones again are very good because sometimes in osteomyelitis, there is now evidence that oral regimens, as long as they have good bone penetration, have uh, same outcomes as intravenous antibiotics. Of course, abscess, aminoglycosides are known to have poor penetration to abscesses, and in the lungs, like for example, daptomycin, they're known to have poor penetration to the lungs. So you avoid certain antibiotics in certain infections, depending on the organ penetration characteristics. And then the critically ill, of course, for critically ill, especially in shock, when your patient is in shock, your GI tract is not working. They're stunned. It's stunned, no. So oral absorption is poor. So you avoid using oral antibiotics in shocky patients, no. And they need quick levels, so an intravenous antibiotic is preferred, of course. And then for pharmacokinetics and dynamics, beta lactams can be infused in a prolonged or extended infusion, and that optimizes the PK/PD of the drug itself. No? So take those into consideration as well. So number 7, fundamental principle: de-escalate antibiotic therapy based on your microbiologic results and clinical and biomarker responses. And that means you have to exert effort in getting your culture specimens, especially at the start. Of course, that also entails clinical and biomarker baseline tests as well. So, for example, for de-escalation, you can use the gram stain. So, a urine gram stain, and it shows gram negative, then you can withdraw gram positive coverage, or in the bloodstream as well. If the lab reports to you or calls you, oh, you have gram positive cocci in the bloodstream, then you can withdraw the gram negative already. Now, so bacteremias and pneumonia, same. Like for example, in CAP, in CAP-MR or moderate risk pneumonia or even high risk, it's recommended to start empirically beta-lactam and something for atypical coverage. However, if the culture already shows that it's strep pneumo, then you can stop the atypical already. And of course, if a patient has showed some clinical response already, such as fever lysis, significant decrease in white count, significant decrease in procalcitonin, you can use this to help prompt you to de-escalate your antimicrobial. And then fundamental 8, if therapy is not working, consider source control and alternative diagnoses before blaming resistance and broadening therapy. So first, consider source control. That's first. Okay, before you consider resistance. Second, is it bacterial, or is your diagnosis correct? Okay. And third, is it really infectious? It may be non-infectious. So those are things. So meaning you might need to dig deeper in terms of the diagnosis, because if your diagnosis is wrong, naturally your treatment will also be wrong. If it really follows. So try spend time really to make the diagnosis, because this will really help your management. Okay, and it will help the patient. And fundamental number 9, distinguish a new infection from failure of initial therapy. So sometimes when you're treating a patient is getting better, and then it seems like the patient relapses. Is it really a relapse, or is it a new infection? So those are the things that you have to again think about. No, so for stable patients, it's recommended to change your antibiotic one at a time, so you know where the patient is responding to, or which one is failing. However, if it's a critically ill patient, you of course it's better to change the antibiotics at the same time. No? So you have less time in a critically ill patient. And the last fundamental is duration of therapy should be evidence-based and short course whenever possible. No? Of course, you look at the guidelines. Guidelines usually have a lot of evidence there, and then of course there's consensus as well. No, whether the evidence is good evidence, no, or not. No, so look at guidelines, and of course, short course whenever possible, and that includes using biomarkers again. No? Procalcitonin has been shown to reduce antibiotic duration by more than 25% in some studies. So again, duration of therapy should be evidence-based and short course whenever possible. Of course, there are some controversies. Cidal versus static. There's increasing evidence that clinical outcomes are not improved in bactericidal versus just static agents. No? Although there are some studies that show that Cidal is better, but those are the minority. And combination therapy, and for combination therapy, you can use that to ensure adequate empiric coverage. Okay, so for example, in CAP, in pneumonia, moderate risk community acquired pneumonia, you give antibiotic for typical pathogens and then for the atypicals. So then to prevent resistance emergence, for example, TB, that's why you give 4 drugs for intensive phase, and to improve cure. Okay. Of course, no to combination if there's redundancy. For example, you already have piptazo that has anaerobic coverage, okay, and you add metronidazole, so it's not needed, okay. So again, try to avoid redundancy. So for the conclusions in Mandel, antibiotics are miracle drugs that fundamentally altered the practice of medicine, yet their incredible power to cure and heal is fleeting. The more we use them, the faster we lose them. And the transmissibility of resistance results in a shared risk across society. When any one of us uses an antibiotic, it affects the future ability of that drug to be available as an effective treatment for everyone else. So there's a societal component as well, or consideration. No one has a right to waste this shared societal trust. One of the founding fathers of anti-infective chemotherapy, Dr. Walsh McDermott, wrote, "It is not too much to state that the introduction of antibiotics has represented a force for change in the 20th century of the same general kind as James Watt's modification of the steam engine in the 18th. The crossing of the historic watershed should be felt at the time. One day we could not save lives or hardly any lives. On the very next day, we could do so across a wide spectrum of diseases, and this was an awesome acquisition of power. Experts with training in ID bear the burden of being at the front lines in the struggle to heal and cure while preserving this awesome power and preventing its disruption of our ancestral microbiome in the process." But again, it's not just ID, it's really all doctors and also not just doctors, even vets. So we go to the summary. So we mentioned we we read about the brief history of antibiotics. We looked at the problem of antibiotic resistance. And let's not forget the 10 fundamental principles of antibiotic therapy. Remember, antibiotics have become a precious and finite resource, and we have of course responsibility for our patients, but we also have a responsibility as well to protecting our society, making sure that we do not increase the risk of dying because of antibiotic resistance. Thank you so much for your attention, and God bless.